Assalamu alaikum. Good evening, everybody, and welcome to the second episode of webinars. That's in collaboration with the American Diabetes Association. The Emirates Diabetes and Endocrine Society has launched a series of webinars mainly to cover technology and diabetes care. And the title of today's webinar will be The Role of Technology in Modern Diabetes Management. It is a live webinar, CMA accredited by Dubai Health Authority. And once you register, you're going to receive your CME certificate within a period of 14 days from today. Welcome to the second episode. Remember, by the end of this session, we're going to have a Q&A session. So if you have any questions, please write them down. We're going to respond to them. As mentioned, this webinar is launched as collaboration between the American Diabetes Association and the Emirates Endocrine Society. And it is our pleasure to go on to the second episodes of this webinar. Could we start with the first speaker, please? Okay. Our first speaker is Dr. Asma Jassim. She's a consultant pediatric endocrinologist and diabetologist at Rajid Center for Diabetes and Research. She obtained her medical degree from Kuwait University, followed by a fellowship in pediatric endocrinology at McGill University in Canada, certified by the American Board of Pediatric and the Royal College of Physicians and Surgeons of Canada. She has 25 years plus experience in clinical practice in UAE and Canada. Expertise in management of all types of pediatric diabetes and endocrine disorders. Skilled in advanced diabetes technology, insulin pump, CGM, and FGM. Former consultant at Dubai Hospital and Dubai Health Authority. It's our pleasure to have Dr. Asma today with us. And to add to this as well, she is a board member of the Emirates Diabetes and Endocrine Society. The title of the talk will be Challenges in Current Management of Pediatric Adolescents. The floor is yours.
Thank you, Dr. Jamal, for the introduction. So, okay, can I go? Can you see my slides now? Is it clear?
Yeah, but yes, but could you enlarge it? Yes, presentation mode. Yes, excellent.
Okay, perfect. Okay, so my talk today is about the, as Dr. Jamal mentioned, about challenges in current management of diabetes in children and adolescents. I just want to make this, okay. So we know that that in spite that we have an excellent guidelines and very powerful technology in diabetes, but despite of that, the reality in reaching the HbA1 target is far from the recommended in the guidelines. So if we just look at this slide, which showing us the a comparison between two registries. So the type 1 diabetes exchange in USA showed that around 18% of children and adolescents reach the hemoglobin A1C of less than 7%. And if you compare that another registry, which is in a high resource setting, like the Norwegian registry, you see that around less than 50%, so around 43% of children reaches hemoglobin A1C of less than 7%. So my talk will go through the why we cannot reach this challenge, this target. So just to make things much more simpler, I divided the challenges in a category framework, starting from disease prevalence to a disease diagnostic dilemma and so on. And I'll try to go through these challenges one by one. So if we start with the disease prevalence itself, if you see that the data from the IDF Diabetes Atlas 2025 showed there is around 1.85 million, 1,850,000 children diagnosed with type 1 diabetes. And this is far significant increase from the previous estimate. So if you look on here on your right-hand side, in 2025, this is our 1.85 million, while you see in 2022, the rate of, or the incidence of type 1 diabetes in children was around 1.2 million. This means that there is around 2.4% annual increase in incidence in type 1 diabetes. And to make it into numbers, there is around 222,000 cases, new cases of type 1 diabetes diagnosed in children. So this is about the challenge of the incidence of type 1. But if we move to type 2, even if it's more honestly terrifying, where if you see the data here, it shows there is almost doubled in the incidence of type 1, type 2 diabetes in 16 years. So this is from the search study, this graph. It shows in 2002, there were around 9 cases per 100,000 youth with type 2 diabetes, while in 2018, that rate reached up to almost 18 cases per 100,000 youth, which means there is a 5.3% increment in annual increment in the incidence of type 2 diabetes. And if that continues in that way, there will be around 700% projected increase by 2060. Now, if we go more focus about our region, which is the MENA region, the Middle East and North Africa, this is one of the hottest regions with high incidence of diabetes. And the information from the IDF Atlas shows that there is around 92% increase in cases by 2045 if these things stay the way it is. Here in UAE, there is around 14,129 youth with type 1 diabetes. And just to take a number of how much cost these care of type of diabetes a child costs. So the cost of treating one child of diabetes reaches at least 15 times more than treating a normal child, a child without diabetes. So if we move to another challenge, with the second challenge about the diagnostic dilemma. So it's not like the before when we have the cases were straightforward that you could diagnose type 1 diabetes easily through the history and type 2 diabetes itself. No, there is now distinguishing type 1 versus type 2 versus monogenic diabetes become much more difficult, especially with the increasing of the obesity in youth. Now, not only that, other factors including the younger age of diagnosis of type 2. So we used to see the type 2 more in the adolescent or early 20s, but now you start to see them very, very early, type 2 diabetes. Adding to that, the atypical presentation of these patients. So many type 2 present with type 1-like pictures, and many type 1 present with pictures which is not very familiar, not very common for type 1, like an autoantibody negative type 1 presentation. And also to add to the risk of challenging at the time of diagnosis, that many of these patients with type 1 especially present late. They present a DKA where they will need an ICU admissions, and the cost of treatment will be definitely much more higher than they present simply in hyperglycemia. Now, just to go into, this is a case scenario about patients showing how the incidence of diabetes, or when we have a double diabetes or diagnostic dilemma. So this is one of my patients who was diagnosed at the age of 9 years. She presented typically with a history of polyuria and polydipsia. She was obese with a BMI of 32. Around, so her BMI was around 120 to 130 percentile for her age. She was having signs of insulin resistance with againthus nigricans. Her hemoglobin A1C at the presentation was 8.2%, and her test shows that she had antibodies positive. So she had her GAD antibody and zinc transporter were in thousands, and her C-peptide was in a high range as well. So if we go to the just simply about the clinical conflict, so the phenotype in this case suggests it's a type 2 diabetes because she is obese, she have insulin resistance with signs of acanthosis. She also have preserved C-peptide. The mom, also there is a family history of type 2 diabetes. The mom during her pregnancy, the pregnancy with this child have gestational diabetes. Then later on she developed type 2 diabetes. But if you go, she have also features of type 1 diabetes. She have 2 positive antibodies, which really confirms that she is a type 1. And plus she have a younger sibling who was diagnosed at the age of 7 years with type 1 diabetes. So, so this is a really very clear picture of a patient with a double diabetes. So now she's almost 3 years post-treatment. She was managed only with metformin and she was doing well. The highest dose she rated was around 1 gram and she was hemoglobin A1C was maintained, but recently it was deteriorated a little bit with, if you could see, this has a very recent CGM for her. So she had her target was only at 63%. She had no lows, but definitely hyperglycemia. So for that, another agent, a GLP-1 agonist was added to her treatment. So this is tell you that around 30% of youth with type 1 diabetes are now overweight or obese, and at the time presentation makes their diagnosis a bit blurry. If we go to the third category, which is the therapeutic challenges of diabetes. Now, as I mentioned earlier, that the SPAC guidelines clearly dictated that the recommended HbA1c is less than 6.5% is the recommended HbA1c if it's safely achievable without significant hypoglycemia or a quality of life burden, and less than 7% is recommended when the tighter control of 6.5% is not reached, especially in children when there is a lack of technology use. Now, again, we're just going back to the registry, but this is in spite of these target range, which is very clear that the target is not reached. And one of the very common factor why the target HbA1c is not reached is the hypoglycemia, which remains the most frequent acute complication of type 1 diabetes and the primary limiting factor in achieving glycemic control. Now, if we go to the hypoglycemia itself, there are 2 factors which affects the hypoglycemia. One is the physiological factor and then the psychological factor. So the physiological factor is many of these young children will have a hypoglycemia and awareness, and which with that I mean that even lack of the symptoms that indicate that the child has hypoglycemia, like shaking, sweating, and especially in young children where the verbalization or communicating the symptoms are much not clear, or most of the time the hypoglycemia is asymptomatic, and this will necessitate that you will have a higher glycemic target range. So this is from the physiological point of view. If you compare that to what happened on the other side in the part of the caregiver, that will increase the anxiety in the caregiver. So in both leading to a defensive snacking and insulin emission or maintaining a higher glucose level to ensure safety, especially during night. And of course, all these periods of hyperglycemia have a detrimental effect on a long-term complication of diabetes. Now, let me tell you about, this is also one of my patients who is currently 8 years and 4 months old. She was diagnosed with diabetes when she was 2 years old. She was presented in severe decay a year after she was diagnosed with celiac disease. Also during her follow-up, we noticed that her growth, she was like having growth failure. Her growth velocity was on the lower side. So she was investigated for the short stature, and she was found to have a neurosecretory dysfunction of the growth hormone secretion. So started on growth hormone therapy, which we know that itself will cause hyperglycemia. So this is an 8-year-old child which having double autoimmunity plus a growth hormone plus a shorter stature secondary to a neurosecretory dysfunction of the secretion. But in spite of that, just look at her CGM. So her HbA1c is being in the range of 6.3% to 6.7%. Okay, but look at the amount amount of the hypoglycemia this child is having. So there is around 14% of hypoglycemia seen very clearly in this CGM, which we call it that the hypoglycemia paradox, where there is excellent HbA1c that mask the significant hypoglycemia illustrated by the tight control and the safety. Now, the main issue in this patient is the parents really, this is maybe, let me say, that's like maybe uncommon scenario where most of the parents are scared of the hypoglycemia, but these both parents were really very, very scared about the hyperglycemia, and they were providing a very tight control on her diabetes. And just to mention, imagine this child, even she is not on insulin pump, she's just on an MDI. So if we move to the other challenge, which is the technology challenge itself, we know that the technology have improved the diabetes care in a very different ways. So one of the advantages of the technology is it will give you that the real-time data, which will enable you to have immediate decision, and that's also this is associated with lower HbA1c. It's safe because it will allow you to have an early intervention for a glucose excursion, and it's also allow you remote monitoring for the caregiver. It improves quality of life. So many parents, once they started have the CGMs and the pump, they will started to sleep at least in a better way, where they know what is happening during the night. And also, it of course definitely it's a continuous, so it at least it show you the trend, what happens during the time, where normally the finger sticks, what will not give you the real life, what is happening between the two finger sticks. Okay, so that's the positive part of the technology, but there's still there are barriers, or there are negative parts of the technology. And what's the negative is they are insertions. So there are painful insertions. They cause a lot of skin irritation, especially adhesive irritation. Don't forget the areas on the body surface area of the children is very small. So even the fatigue, or the area fatigue, they can develop from the frequent use of these gadgets. There is so much data, so that these patients can get overload with the number of the data that they get constantly, and there is literally say that there is no break from diabetes. Other than that, we don't forget that these are expensive, they costly, and in many countries they are not covered. And covered, even in the countries it's covered, is not the insurance or all the categories or all the level insurance covers type 1 diabetes or the insulin pumps and sensors in many places. So this study shows that why technology itself can cause, or why families discontinue use technology despite of the benefits. So one of the very common reason of patients discontinuing the use of technology is the alarm fatigue. So that's continuously getting alarms, which make them literally feel that there is no break from the disease. Other factors is like body image, that getting stigmatized with all the gadgets that they are wearing. There are other issues related to the device itself, or the physical discomfort from these gadgets. Now, if you go to the psychosocial burden, I will mainly concentrate here about the psychosocial burden in adolescents. And these adolescents, many of the adolescents develop diabetes distress, and this is different than depression, where diabetes distress affect around 1 in 3 adolescents. And diabetes distress itself is make them at a higher risk of developing depression compared to their peers. Don't forget, adolescent at this age, there's a lot of family conflict. Either there is a premature transfer of the care from the family to the adolescent, and maybe he will be immaturely providing care which is inappropriate or not reaching the recommended HbA1c level. At this age, we, as know, the adolescence is at this age, they're taking high-risk behavior is much more common, and using of alcohol, substance abuse, which also will affect the diabetes control. Adolescents at high risk of having peer influence at this age, and they prioritize their peer influence more, and it's more important for them than having better medical adherence to their diabetes care. And on the top, to add that often from the busy clinic, that we often forget to screen for these. So whenever we know that this is psychosocial burden need to be screened, and if we don't screen, so if you don't screen, you will never know, and if you you will not be able to interfere. So the other factor which has caused the decrease in the diabetes control in these children is the transition time. So children at this age, during the adolescence in many different countries, is the time where they will be transferred, the care will be transferred from the pediatric clinics to the adult clinics. Now, this is a very critical area where affects the diabetes control in these children. So the transfer from pediatric to adult care represents the highest risk period of loss of follow-up, with the clinic attendance dropping significantly. And there is around 10% increased risk of hospitalization with DKA or hypoglycemia within 4 years of transition. If we think about the behavioral and lifestyle, I will just quickly tell you about this case where how the psychological effect of both hypoglycemia and hyperglycemia affects the management of diabetes. So this is a child patient with also the celiac disease, type 1 diabetes and celiac disease, who was diagnosed at the age of 8 years. She was presenting with recurrent hyperglycemia and ketosis, and basically because of very poor family circumstances, limited education of the parents, and there is no really primary caregiver. But recently she started to come with hypoglycemia, and she was admitted, a few days or like a few weeks ago, with hypoglycemic seizures, and the cause of the seizure was manipulating of her insulin dose. So you can see in one case we're moving from hyperglycemia over to recurrent hypoglycemia. And here you have to think that you only not have to treat that the blood sugar, there is other factors need to be taken into consideration. So the basic thing was done with this patient, this as a part of her safety, that she was moved to a simplified regimen using a co-formulated insulin to make her life much more easier and prevent at least these life-threatening complications. Now, if we go to the systemic barrier, there are lots of systemic barrier that prevent the optimal control of diabetes, including the fragmented care model, limited access to multidisciplinary team, delay in the approvals of the CGM and pumps funding, and the variability of school readiness to treat patients, short appointment times. All these are factors that affects the type diabetes management in children. Just to mention about type 2, the 80% of children with type 2 diabetes come from very from background with low socioeconomic circumstances, or from ethnicities like Hispanic or Black with a limited parental education. And many of these families have a low income, which makes their insurance coverage is to be like a poor insurance coverage, which doesn't allow them to even attend tertiary centers or a center specialized in diabetes care. Just lastly, I mentioned about the early complication. We know that the complications are very common in type 1 and type 2 diabetes, with a very clear guidelines in the all the ISPAD and the ADA guidelines about screening them of both type 1 and type 2 diabetes. But if we come about saying just about the type 2 itself, now it's very aggressive disease in young youth. So the study from today's study in diabetes shows that young children who develop diabetes at early age, by the age of 26, around 60% of them will have at least one complication. So imagine at this age, so they will develop complication much more faster than compared to their peers. So bottom line, what we see that the hemoglobin A1C, level, we see the time in range, we need the average glucose and the glucose variability. But what you see is 10%. What is hidden is more than 90% of the challenges are hidden under and that need the intervention. So I think maybe if I have a short time, that's at the just to for better intervention, it needs a collaboration. It's a collaboration between you have to intervene, collaboration at the patient's level, collaboration at building a proper team, which making the multidisciplinary team access to all the patients, and without having any restrictions from the insurance, because we know that in many settings that the coverage of the dietitian, covering of the mental health is not being covered by the insurance, which make the patients doesn't attend these visits. And empowering patients at the first, and educating these families so they will have a good education and maintaining a good transition care for these children into the adolescent. And with that, I would like to finish my presentation. Thank you.
Many thanks, Asma. Your talk was easy to follow, very clear. Thank you so much. Thank you. We'll move on to the second talk if Dr. Muhammad is available. Okay, and waiting for Dr. Muhammad to join us. Now, Dr. Asma, I'll just wait while waiting for the second speaker.
Yes.
What's the cost of using the pump and the insulin pump and the CGM overall?
What is the cost?
So if we take it like annual cost, how much the cost would be?
Well, I mean, if you remove well, it depends also. You know that we have different types of insulin pump. I just want to maybe, there are pumps which are the single time user, and there are pumps which are that you need to change them frequently. But if you take those with those who require the consumable change every 3 days, so that cost is around, like, let's say it's like around 1,500 dirham monthly, excluding the pump, which is like a one-time life use.
Yeah, so you're speaking about something like probably between 15 to 20,000 dirham per year.
Yes,
almost.
It's around.
Yeah.
Yes.
Okay.
Yeah.
Right on. And please, once again, if you have any questions, write them. We're going to respond to them by the end of the sessions. Our second speaker is Dr. Muhammad Hassanin. He's a professor of medicine at Mohammed bin Rashid University at Dubai, senior consultant in endocrinology and diabetes at Dubai Hospital, co-founder of Cardiff University Diabetes Diploma, a master's degree since 2007. Main research focus is diabetes and Ramadan, and co-authored the global guidelines on the DAR guidelines, published more than 100 papers, and authored the Emirates Cardiometabolic Guidelines, associate editor of the Dubai Diabetes and Endocrinology Journal, won the first prize of the Diabetes Education Program from Diabetes UK and the European Association of Study of Diabetes, served as a consultant in endocrinology and diabetes in the UK since the year of 2002. And of course, he is the founder of the Diabetes and Ramadan International Alliance. And a few weeks ago, we had the international conference in Dubai, and it was a hybrid conference. Today, we're going to speak about challenges in current management in adults. The floor is yours, Dr. Hassanin.
Thank you very much, Professor Joma. Great pleasure to be with all of you. And let me share my slides.
Just Yes,
Can you
now
see
we
my
are
slide
ready.
clearly?
Yes, clear.
Okay. So after the excellent presentation of Dr. Asma for the challenges in pediatric field, I'm going to address it in adults field, primarily focusing on type 2 diabetes, as the other speakers will be focusing, I guess, on type 1. So what we know about type 2 diabetes, that it's really quite a disease that can cause lots of morbidity and mortality. Even every 6 seconds, a person will have one of these complications, a cardiac heart attack or a stroke, a retinal problem or a kidney problem or a foot problem. And we need to ask ourselves why, specifically thinking of our region. And it's really important that when we think of the why, we think of the population and the people rather than just the disease, because certainly the disease could vary from a place to place. Now, if I think of Dubai over the last 60 years, I've been a visitor in the past. I've been working here now for 10, 11 years. And every year we see a change, an increase in urbanization. In fact, we've been chatting before the session and we're all talking about how busy the cities are with the popularities of the country and of the city. Now, with urbanization comes wealth, but also come, unfortunately, some bad habits, primarily sedentary lifestyle, as well as junk food, which obviously can affect biochemical factors, glycemia, hypertension, dyslipidemia, obesity, and type 2 diabetes. Certainly, the influx of Western style of food, coupled with the generosity of the traditional Arab generosity and the plethora of food that is available, makes eating here quite tasty, quite attractive, but obviously with a price to pay of weight. And there's been a change in the type of food. Now, classically, all guidelines says that every one of us should have 5 servings of fruits and vegetables. And when we asked in the Ministry of Health, in their national survey a few years back, how many people are not receiving or having the 5 servings a day, and we found that 82% are not. So this is not what people do, it's what people are not eating. So 82% are not having this, whether they are Emirati or non-Emirati, and whether they are men or women. When you look into also the data that we've published from the Dubai Household Survey, a WHO style survey about physical activity, and the first question was about spending 10 minutes during different types of physical activity at work or at home. And people do it daily, 10 minutes, only 17%. When we asked about the more vigorous exercise, which in all essence wasn't really vigorous, it was 10 minutes, such as playing football or running. Who is doing this daily? Only 5% are doing it daily. This is not just a problem in Dubai or in UAE. When we asked people about their physical activity from the Middle East and North Africa region, 22% said they are inactive. Another 41% said they are with low level of activity. So when you add them together, you clearly see that nearly 2/3 of the region are saying they are either inactive or with low level of physical activity. When you put these together, no wonder you see that obesity in red is getting higher over the years. 24% in 2009 to 39.9% in 2019, because of the reduction in the adequate intake and the not significant change in level of physical activity. So consequently, that results in obesity. This is the data from the Dubai Household Survey of 2019. And as you can see, green is a normal BMI, and only 42% of the population have a normal BMI. And that obviously is a serious cause of concern. Now, we need to understand the population of Dubai. And this is from the Dubai's Household Statistics, the Statistics Center. And Dubai is and the same for Abu Dhabi. So the country in general is a very young population country. 70% of the population are below the age of 40. In fact, if you are to dig deep and look into the figures here of those who are above the age of 65, they are not many at all. Very small number. So that is very serious. Why? Because if we have that level of obesity in young people in their 20s, in their 30s, as per the household survey, and as well when you look into overweight and obese in adolescents, 13 to 18, 31%, nearly a third of our young generation who are meant to be the most active, a third of them are overweight or obesity. And when you know that the country is largely very young people, then you feel the alarming bells of the challenge of the future for diabetes and obesity and related conditions. Obesity is not just simply looking at the mirror and saying, I look obese or I look overweight. Obesity is very much linked to metabolic problems such as diabetes and fatty liver disease, like cardiovascular disease, certainly impact on the bones and even cancer. So that obviously is a very serious health problem. The WHO and the World Obesity Federation have considered that death from non-communicable diseases due to high BMI in United Arab Emirates to be pretty high, and of it, diabetes is 1,000 deaths per annum, coronary heart disease 2,667, and of which stroke is nearly 1,400. And of course, cancers as well are there. And it's not just about death, but about prevalence of diabetes. Have a look here into the data that we've done from the survey in 2017. If the person is of normal body weight, the prevalence of diabetes is 8.2%, and that's even lower than the international rate of 9.4. But if they are obese, it jumps up 2.5 folds to 21.5%. And that was more or less the same in the following surveys of 2019 and 2024. Now, the problem is not just about diabetes, but about other cardiovascular challenges. Here in the survey, we've measured the blood pressure on 3 consecutive measurements for people in their own home. So it's home blood pressure management. And at the time, we considered in the general population that below 120/80 is good, between 120 to 140 or 80 to 90 is pre-hypertension, and above 140/90 is hypertension. And as you can see, it is distributed as third. So a third of the population clearly have blood pressure that is considered to be high, and another third are not too far. Now, unfortunately, smoking, and specifically shisha smoking, have become a fashion and a trend. Rather than being a taboo or socially unacceptable between men and women, data of 10 years ago did show a much lower rate of female smoking, which we know is usually underestimated. But look here into the male smoking, 21%. So that's more than 1 in 5 are smokers, let alone the ex-smokers. So when you add them together in men, it comes to nearly a quarter of the population are a current smoker or an ex-smoker. Now, unfortunately, lipids management is also not ideal. This is data from our diabetes secondary and tertiary care, and certainly the target is not less than 100. The target is less than, in some people's eyes, less than 70, and for many, less than 55. And we all know, those of us who work here, the massive impact of negative social media on many people stopping their statins. And maybe that plays a role, and maybe it's other factors that is contributing to not achieving the right LDL. So we need to think of what are we facing in the population, and then we think of what we are facing in our clinics. Hyperglycemia is a very big challenge. a big challenge that we are not able to address despite the massive resources that we have in the country. And we know that hyperglycemia will have an impact on microvascular complications, retinopathy, nephropathy, and neuropathy, as well as macrovascular complications, stroke and cardiovascular disease, and peripheral vascular disease. So we need to try to do something. And if you look into the East Mediterranean region, and I've highlighted here in red, for every single, I've here highlighted the Southeast Asian region as well as the East Mediterranean region, because that's more or less what constitute the population of Dubai, people from United Arab Emirates, as well as from neighboring countries, whether from Asia or from other Arab Mediterranean countries. And unfortunately, we have very high prevalence of all of these serious problems that causes a challenge to the service. And despite the excellent infrastructure that we have, achieving an HbA1c of less than 7 is not really pretty high in many of our centers, and this is data from Dubai. But Dubai is not the only place. I personally worked in UK for 24 years, and the data from UK says that only 40% are less than 7% HbA1c, and the same more or less in most of the European countries that have a very good health system in compared to many other global countries. Expanding a bit, and this is data that I've looked into from nearly 6,000 persons from 12 different countries, the overall HbA1c of less than 7.5, which by no means is not the target, but just as a pragmatic target, it was 36%. So again, it's the vast majority are not with this. And again, we know while hyperglycemia causes problems, improving hyperglycemia, improving HbA1c by 1% can reduce death, microvascular complications, and macrovascular complications by a very significant factor and a very significant percentage. Now, the problem is not just morbidity and mortality. The problem is also financial on the burden for the person, as well as, of course, the health organizations. This is American data, and certainly when you add to it the cost of obesity, whether it's bariatric surgery or the classic powerful drugs that nowadays we have, it's pretty expensive. Whether we are talking about the US or UAE, it is expensive everywhere. So financial burden is a big problem. And instead of us trying to think of why, we have the headlines, and these are headlines in UK about the jab that can fix the problem and fix heart attacks. While of course, as physicians, we have always been taught, treat the cause. And the cause and the treatment is not just in giving a jab. Of course, these injections are excellent efficacy and have excellent data, but we need to think of the challenge. The true challenge is the root of the problem, the cause of the problem, which is the lifestyle. When we wrote the cardiometabolic guidelines between us as endocrinologists and the cardiologists in United Arab Emirates, we were very clear, similar to the ADA recommendations and all other recommendations, lifestyle is a core intervention. Thinking of the sedentary lifestyle, the diet, losing weight, stopping smoking, regular exercise, better sleep, better management of stress, and of course, attending regular checkups. All of these are very important aspects, but unfortunately, we tend to focus on improving the buildings, improving the equipment, getting the latest drug, and we do not focus very much enough time on treating the cause, which is the lifestyle, as I've shown you. A big factor that is missing is education. Education not for us as healthcare professionals, the societies and the organization are doing that in abundance. But we are missing education to the people with diabetes as well as the general community. In fact, when we know about hypertension, that sodium is bad, but potassium is good, and checking the blood pressure at home is as important as blood glucose monitoring. Stopping smoking when we see 21% of the male population are current smokers. That is a very serious problem indeed. We live in a region that is surrounded by countries that have abundance of fruit and veg. So eating that little fruit and veg is really quite an important factor. Taking our lipid lowering agents and listening to the healthcare professionals of eminence rather than the bloggers and the TikTokers is really quite important, and understanding the impact of physical activity and sugar. Physical activity is really quite important. Does it work? When I was working in UK, we did this fantastic study on structured hypertension education. I put here the photo of Professor Ingrid Mulhauser from Germany, who helped us with the program, and we modified it and applied it. And we randomized people into two groups, a group that received structured education for hypertension, as well as home blood pressure monitoring, and the other group, which was standard treatment group in UK in secondary care. And you clearly see the difference. In orange is the routine group, and here is visit 1 after 12 weeks and visit 2 after 12 weeks. The percentage of people achieving the blood pressure target is much higher and with less number of pills. So adherence to treatment as well as efficacy of the treatment was achieved with a tiny increment of blood pressure treatment versus triple the increments in those who received the routine care. So education is key in achieving all of this. When we educate people, they learn, and this is very interesting because I found it fascinating that the mirror image of the word teach is learn. And if tonight in this webinar or this morning, if you're in the States, after the teaching people learn, then the purpose of the exercise has been achieved. Now, we do have venues for physical activity. The government is trying hard, but as you can see, they are not really packed. And initiatives such as His Highness Sheikh Hamdan initiative for 30 days of 30 minutes fitness exercise and challenges helps to make people more conscious and more aware and engage more and more. So we need definitely to start prescribing physical activity as much as we prescribe other medication. Physical activity is the mirror image of weight. A person who is physically active, her prevalence of diabetes of 8.8%. A person who is not exercising is 21%. Exactly the mirror image of obese versus normal weight. So increasing our physical activity, even without changing the weight, would help to address the challenge of diabetes that we've been talking about. This is my pre-last slide. We are here for a webinar with collaboration between ADA and EDES with technology. And I think technology can help in all of the aspects that we've talked about. Finding the person who's at risk, doing the patient education as well as the public awareness education. The glucose monitoring and the insulin delivery technology are all very important, and I'm sure during the session of Dr. Asma as well as the future sessions, we have heard much of this and will hear more of this. But I have tried very much to address that the change in lifestyle, the urbanization that happened in the region and in the country is a big challenge that has led to significant change in lifestyle, that has led to the epidemic of obesity, diabetes, and cardiovascular disease. Hyperglycemia is obviously directly related to all diabetes-related complications, whether it's microvascular complications or macrovascular complications. And of course, hyperglycemia would be present in people who are eating the wrong type of food and not physically active. There is strong evidence that confirms that it's the essential role of structured education in people with diabetes and pre-diabetes. But this requires diagnosis early enough through a culturally sensitive structured education program, and to be delivered by trained people with the use of smart technology, because the cohort that we want to reach is massive. is in millions. Of course, behavior change is required in all people with diabetes, prediabetes, and obesity, and that's not difficult to achieve. We have seen lots of positive behavior changes, and we also seen negative behavior changes, so it is possible to happen. Better eating habits and improved level of physical activity appears to be a key factor that needs, of course, the collaboration of all stakeholders to address. I stop here and I look forward to the Q&A session. Thank you.
Many thanks, Professor Mohammed Hassanein. It's coming up. No, that's good. Please, if you have any questions, write your questions. We're going to respond to it by the end of the session. Our next speaker is Professor Daniel Jarmowski. He's Research Associate Professor at the University of Virginia, expert in diabetes technology, co-author work with the Nobel laureate Oliver Smithies in diabetes nephrology, led major clinical trials on closed-loop insulin delivery for type 1 diabetes, advocate for advancing artificial pancreas system and patient-centered diabetes care. He published over 40 papers, senior editor of the Artificial Pancreas, and his H-Index 29. It's our pleasure to have you today. And the title of the talk will be The Role of Diabetes Technology in Overcoming Challenges. The floor is yours. Professor Daniel, could you, yeah.
Perfect. Can you see my screen perfect? Good?
Not yet, no. Now starting, yes. Yes.
Oh.
Yep, it's
Okay.
there.
Thank you for inviting me and in this distinguished panel. I have a lot of slides, but some of them were covered before by Dr. Asma and Dr. Mohammed, so I will try to go fast to some of these to comply with the time. As I was introduced, and thank you for the introduction. My name is Daniel Czarniawski. I'm a research associate and a professor at the Center for Diabetes Technology at the University of Virginia, as well as member of the Executive Board of International Society of Pediatric and Adolescent Diabetes. So the points that I'm going to cover are glucose measurement devices, medications, infusion, which are delivery devices, and more modern devices, which are called automatic insulin delivery system or AID systems. Some overview of what we have in the past and we still have and we still use. The previous speakers talk about all the technology is available, is costly, and not everybody can afford it or have it in every country. So there are many people in technology for glucose monitoring. They are still using self-monitoring blood glucose or glucometers, and the more modern and the continuous glucose monitoring. Technologies for insulin delivery are the insulin pens and the continuous subcutaneous insulin infusions, or most commonly known, insulin pumps. So for glucometers, in the way they work, they measure whole blood glucose, and that's important to mention because it's a difference where CGMs or continuous glucose monitorings, it needs teaching. The previous speaker talked a lot about the teaching, and my entire talk will be important to emphasize that the devices are available, they work perfect, they are fantastic, they improve the treatment, the modern treatment of diabetes, but teaching always needs to be present. Otherwise, they don't work. The system per itself is not working if there is not a support in the family, in the friends, in support groups, as well as the healthcare team that can accompany any device that is recommended or prescribed to a patient. The gold standard still is the glucometer for point of care for in and out patients, and it needs several components. It needs the device per se, the glucometer. It needs proper teaching in cleaning fingers with pads or alcohol swabs, pens and lancet applicator, and the lancet, as well as the test strip that is needed for the use of glucometer. Now move fast to the continuous glucose monitoring. It's considered a wearable device. It's small and discreet. It can be wear in the arm or in the abdomen. Measure interstitial fluid glucose concentration, and I will talk a little bit about this more. It's minimal invasive, and it has three components: the sensor, the transmitter, the receiver, or the app. I'm not mentioning the applicator because many of the CGMs already come all together with sensor, transmitter, and applicator all together in one piece. It can measure, and I think Dr. Asma covered this, in real time or intermittent measurements. Could it be used alone or connected to a pump or a pen? The most common may last 10 or 15 days, and now there are other more invasive and may last out of 1 year, 365 days. On the right side, there is a picture of a person wearing one, and here is a little bit of diagram of what is composed of a CGM. The continuous glucose monitor continuation, its sensor and transmitter, as I mentioned, can come together, comes with an applicator that also may come together, so it's easy, very easy, and again, it needs to be taught, but it's very easy, as it takes 5 to 10 minutes to teach how to apply, and it's very easy to follow. Measure interstitial fluid glucose concentration every 1 or every 5 minutes. The transmitter works with an antenna, so it has to be close to either, if you use a cell phone, a smartwatch, it has to be very close because it's about 20 feet or 6 meters. It's compatible with many smartphones and smartwatches via Bluetooth. It's integrated into other apps, so no need to use multiple apps. Although each CGM has its own app, it can be integrated with other apps. As it was mentioned before, there are many apps and losing weight, diabetes management, and all the CGMs can be integrated and all can be seen in one app. It gives a quick overview of the ambulatory glucose profile, as I was mentioned. Although if using for inpatients, not every country has approved CGM for inpatients. It could be not ambulatory, but also what you are having in the hospital for the inpatient. This was already shown, so I'm not going to go into much detail, but here is a report of the ambulatory glucose profile that can be expressed in bars, or it can be expressed in diagrams. If we use with smartwatch, it can transmit data to a clinic, so it's very passive or very easy for the user to transmit the data, and when it comes to the clinic, there is no need for downloads, and the doctor can have, or the healthcare team can have all ready to see the patient and the patient information. It's also have alarm and alerts, and this is very important. Also, it can increase the burden. Having so much, it could be alarm fatigue. Having said that, the CGM companies acknowledge that and had a feature that is shut all or silence all except when it's dangerous low. That means lower than 3 millimoles per liter or lower or 55 milligrams per deciliter. It could increase, and this was mentioned before, it could increase the burden. It's sometimes too much information, have adhesive allergies and leaving some scarring. They are minimal invasive, so they are not non-invasive. So it still have some application and can provide and can create some scarring on the skin. And it doesn't work that well when I rapid changes of blood glucose, here in exercising or when there is situations of stress or glucocorticoids, prescription, etc. Now moving very fast to insulin pens. The insulin pens can be connected or not to an app. These are the main parts of an insulin pen. It has an injection button, a dose window, a dose knob, insulin reservoir, which comes pre-filled on the pen cap, the inner needle that has to be changed every day or at least every other application, and it has a paper tap to take it to keep it neat and clean. There are some pens that can be connected. There are some pens that allow a device that will be on top of the pen and can be connected either to the CGM or to the CGM data or to an app, and that it works somehow in a smart way, telling the people if injected or didn't inject it, and when is the next injection and how much they need to inject based on the CGM data that receive, as I mentioned before, every 5 minutes. Moving to insulin pumps on continuous subcutaneous insulin infusion. Can it be a punch pump, means tubeless, or a tube pump? It needs an infusion set that could last 3 to 7 days. It depends which one you use. It needs to be filled. It doesn't come pre-filled, and it's connected or not to a CGM. So I will talk a little bit of the, sorry, I went too fast. I will talk a little bit of the ones that are approved in the United States, which are the more familiar to me. I know in other parts of the world, there is Diabeloop and CAM-MPS. For example, Diabeloop, I know, is approved in the United Arab Emirates, as well as CAM-MPS. And CAM-MPS is also approved in North America and Canada, but not in the United States. So these are a picture of the ones that are approved in the United States. I will mention briefly the algorithms, but this is important to understand how they function. There is one that is called PID, proportional integral derivative. The controllers are simple, widely used, and excel at regulating single input, single output systems. The best example I can give of this that was given to me by the head of engineering in Harvard. It works as your thermostat. You put it at 72, and the system will try to go to that number. That is good, but also can create some problems, as it was with previous iteration of some of the pumps that use PID and can kick you out of the closed loop system very frequently. There is another one which is used for most of the AID systems. It's called Model Predicted Control, or MPC. It's more advanced method that uses a process model to predict future predicts control actions, making it suitable for complex, multiple inputs, multiple outputs, and system is constrained. And again, think this as a Lego construction. You put one on top of another, but they don't need each other to work. They can work independently. There is an algorithm for hyperglycemia, an algorithm for hypoglycemia, and it's silent when you are in range, which is usually 70 to 180, although you can manage the range to 70 to 140 when you use it at night if you so desire. There is new ones coming, which is a neural network. This technology uses what it learns from data to approximate control policies or model. The beauty of this is the most used lately for what it will come, hopefully, which is fully closed loop systems. Most of the systems today are called hybrid closed loop systems. The MPC and neural network can be combined, which it's very adaptable to the new systems that are coming. The automatic insulin delivery system integrate. It's composed of the continuous glucose monitoring that I showed before, an insulin pump, and an algorithm that connect both. The algorithm can be on a phone, on an external device, or it can be included on the insulin pump as tandem, for example, or other insulin pumps, and adjust insulin automatically and deliver based on real-time glucose levels that is informed to the system by the continuous glucose monitor. There are 5 AID systems, as I mentioned, available in the US: the Tandem Control IQ Plus, the Medtronic MiniVet 780G, Insulet Omnipod 5, Beta Bionic iLet, and recently the Sequel Twist. Diabeloop and CAM-MPS are not available in the United States. Each system has unique feature, and I will mention that one by one as fast as I can later in this presentation, but all of them do an excellent job, as it was mentioned before, improving time in range, 70 to 180, reducing hypoglycemia, which is very interesting and very important for dangerous hypoglycemias, providing better overnight control, and reducing long-term complications, as it was mentioned before. Hyperglycemia lead to severe complications that increase the cost, direct and indirect cost of diabetes. The insulin pump manufacturers are ultimately working towards, as I mentioned, a fully closed loop system that will require no user input. It's plug and play, and more devices integrations are expected in the coming years to enhance user choices and flexibility. It was a good point done before by the previous speaker on obesity. Many companies that work in obesity are also working in including CGMs to the people to know the metabolic systems that they can use, or the metabolic states in which they are, and help reduce weight. Which algorithm each pump use? Medtronic all models, 780G, 680G, use PID. The latest model, 780G, combined with fuzzy logic, a system created by Moshe Philippin and his team in Israel, and this allowed to extra doses. The beginning of the Medtronic pump didn't allow that. All the others use MPC, model predictive control. How to choose the right one? I put some advice that this organization, Diabetes-Wise, Panther created in Stanford, Panther program created at Barbara Davis System, as well as Children with Diabetes, although the latest, because this was updated in 2024, and I will put these websites later on for everybody to see. What are the long-term advantages of AID systems? Fewer and less severe episodes of hypoglycemia and hyperglycemia allow for people to stay in range more during the day. Some systems stay 70 or higher, 69% between 70 and 180. And when we use it overnight, that can go up to 90% time in range overnight. Less worry by reducing the risk of severe hypoglycemia. Increased confidence due to the more time in target range. Potential for improving A1C as the person with diabetes stay more in range. It's stable overnight glucose and increase the potential for fasting glucose to remain within targets, which are important for central cultures that have some periods of fasting for different religious purposes. The continuation of AID improves sleeps, and I personally have run some trials giving people the watches or devices to manage sleep, not only the patient, but also I'm a pediatrician also with parents, if they can sleep better, if they can sleep more and improve sleep due to more stable glucose readings and less alarm and alerts. Reduction in diabetes distress, this was mentioned before. Distress is very important, particularly in adolescents, allowing the individual to not have to think all the time about diabetes, although it was also mentioned that too much data sometimes may increase this distress. So it has to have a perfect balance, what we provide and what the person wants to use. Allows for more flexibility in surrounding meals with glucose meters, which has one-time measures. You have to do 6 or 7 pre-meal, post-meal, before bed. Here it allows more flexibility because I know constantly what's happening with my blood glucose, the ability to match basal needs more physiologically instead of presuming someone's basal requirement and are the same day after day. Finally, reduces the daily risk required to manage glucose readings. What are considerations for use of AID system? With any technology, it's important to manage expectations. That's why teaching comes crucial. It's not like we will give a person an AID system and all the problems are solved. That's not the case. It's very important to teach and to manage the expectation of what these devices can or cannot do. Two devices might be worn. Sometimes they may be uncomfortable for a patient, but two is a CGM and a pump. Insurance coverage, it was a good question about the cost. So this is very important because in some countries there is not social medicine and the health insurance had to cover the high cost of these devices. Otherwise it's too expensive. There may be additional alarms and alerts that may be added to the systems. This could be good, but also can create a burden. Basal and bolus settings must be assessed prior to the initiation. So far, they are calling hybrid closed loop. It's not fully automatic. It requires a backup plan in the event that this system fails. So always, we need, even if the person is carrying the system, we have to advise that they also need to carry a needle and syringe, a pen in case the systems fail, because they are going to fail at some point. User must still pre-bolus for food and adjust for exercise, stress, or illness. Time must be allowed for the system to adjust to the user needs. Require user troubleshooting knowledge, that goes with teaching. Requires trust by allowing the system to work even when I'm anxious to give more or less insulin. It depends what I'm eating. I put here, I'm not going to read them all, but it's very good to treating hypoglycemia and hyperglycemia. But the goal of these next slides is how the AID system functions, what are the user responsibility, and when there are some tips and best practices which come with the teaching. In this case, for example, I will read this one. in hypo and hyper, reduce and or suspend insulin delivery when the glucose is predicted to go below a certain level or above certain level, increase or reduce basal insulin or meal insulins, and during the day, the user, it's not advisable to wait when the system is in hypoglycemia. Sometimes the CGMs take more time to detect the hypoglycemia. So when the system, when the symptoms appear, it's important to notice that and to treat adequately. Utilize bolus calculator to correct this glycemic event. And it's important to revisit when you visit your healthcare team, what adjustment do I need to do to these systems? I mentioned cover meals and snacks. So it's important to let the system work and be patient. And sometimes when I'm gonna treat a hyper or a hypo, the doses may change because the insulin was already level as the CGM keep sending the information. So it's already modulated. So I may need less insulin to treat a hyperglycemia, or I may need more carbohydrate if I have a hypoglycemia. It could revert to open loop system, and this is sometimes advised that people that exercise a lot, so it could be used as regular insulin pump with CGM and not with closed loop systems. It can manage physical activity. Some of the pumps had a button in which I can reduce to increase instead of 70 to 180, the bar goes to 140, so it will alarm me before I'm reaching 100 or 140. And I'm going to mention briefly pros and cons of each of the pumps. The Minimed 780G is one of the most aggressive automated insulin delivery systems. It has the lowest target, although it can manage different targets. It has extended infusion set of 7 days. It has meal detection technology, an agreement with Abbott to use with the Instinct. The Instinct is the same as the Freestyle Libre 3, which I know is available in many countries, but they cannot name it Freestyle for commercial purpose, so they name it Instinct CGM, but it's the same one. Although it has some cons, which will be the tubing can be inconvenient for some people. The past CGMs that are still connected has difficult from factor due to its size, and it needs charging and sometimes calibration. It has the PID algorithm, which I mentioned before, and the Simplera, which is the new CGM. It can be used as a connection. It's more accurate, although it's not what is called an iCGM yet. Potentially coming soon for more modern, new algorithm for fully closed loop. Tablet, I know they are working in a patch pump or tubeless, and all-in-one. I have just in a talk by Dr. Vigersky, which is the CMO of Chief Medical Officer of Medtronic, in which he showed a picture that they are working in an integrated pump and CGM all in one device. Tandem Control IQ has similar pros. It's the only automatic insulin system with an extended bolus for up to 8 hours. It has 2 different choices, smaller or larger. It can be managed from the phones. Also has many modes and temporal basal rate, automatic bolus, sleep, and exercise. Also requires tubing, and the infusion sets, it lasts 2 to 3 days, although they are working in the 7 days. And now it's embedded with neural network, which will be faster for fully closed loop, which they are working as well. The Insulin Omnipod, it's the only patch pump available in the United States and works with Dexcom and Abbott. I know in United Arab Emirates, as well as other Asian countries, there are 2 other CGMs, Sinocare and Sibionics. I'm not mentioning here, they are not in the United States or in North America. Some of the contraindication, the pods of the insulin stop working at 80 hours and only can carry 200 units. For people that need more insulin, this could be a problem, and it's also working in a fully closed loop system. Beta Bionics is the most friendly in terms of preparing for it. You just enter your weight and that's it. On the other hand, is the less hands-on. The person cannot do anything. If they have hyperglycemia, they have to wait for the system to work, and there is nothing the person can do. It may work for some people, it may not work from others, and they are also working in a tubeless pump as well as dual hormone, insulin and glucagon. The Circle Twist is the recently approved. I don't have too many cons because not too many people use it now. an important thing is integrated with a very invasive CGM, which is the reference sense that can last up to 365 days. So that's very important. It has insulin dosage adjustment for selecting by emotions. So it's very friendly for every age and everybody use, although this system is only approved for 18 and older, whereas the previous ones are some of them from 2 and older and 6 and older. The companies have their own resources, so are advised to go to the resources of the companies. How to choose an AID system, and I'm almost to be done. It's what appeals to the person about the pump. Is the pump compatible with your current CGM? Some of them are not. How does the automatic system adjust insulin delivery? Okay, if the patient can customize setting like basal rates, activity, some people want to be more hands-on, some people don't like to touch the system that much. Is the interface of the pump, I mentioned some of them we use with emojis, the Ipsomed that carries the CAM MPC, it's a pictographic that would be very good for some people that is not very versed in English. Most of the pumps are in English. What is the maximum amount of insulin? If the person needs more, maybe some that carry 200 units is not the best. If the company has a HEP line that will be available all the time, and how long is the warranty, and this is important because of the cost. Finally, what are the potential problems with the AID? The devices are machines. They may malfunction. The infusion site can have some issues and have to be changed frequently, creating scaring. There is a learning curve, and we have to acknowledge that. I talk about when I talk about the expectation, and of course the cost. Basically, a person with diabetes, with the help of healthcare team, should choose the best system that adapts the most with the lifestyle of the individual. And when I talk to teaching, there are resources for healthcare providers, which is the ESPAD and ADA guidelines. ADA is also partnered with the EASD for guidelines, as well as local society guidelines. And this is very important because we have different cultures, we will not eat the same, we have fasting periods, so it's very important. Here I repeat some of the resources that I put before, and since I'm part of the ESPAD executive board, I want to mention that it's a webinar coming on December 17 that Dr. Asma mentioned. The transition of care is very important. So the webinar coming on December 17 for ESPAD, it's related to transition of care. With that, I thank you very much. And here is more information if after this somebody wants to contact me. Thank you very much.
Many thanks, Professor Stavrovsky. Excellent talk. And we're moving to the third speaker now. As a reminder, if you have any questions or queries, please write them. We're going to respond to you. Our last but not least speaker is Dr. Mohammed Soufiani. He's Assistant Professor of Endocrinology at King Saud University in the Kingdom of Saudi Arabia, Adjunct Faculty at Johns Hopkins University, Vice President of Saudi Endocrinology and Type 1 Diabetes Associations, Chief Scientific Officer of the KERAS, which is AI-powered diabetes platform, completed residency at the University of Buffalo and fellowship at Johns Hopkins, holds a MBBS, a master degree in biotechnology, leads research in diabetes technology and telemedicine, published widely, and delivered more than 200 conferences presentation. Pleasure to have you, Mohammed, with us today. And the title of the talk will be Regional Experience in Technology and Diabetes. Welcome, Mohammed.
Assalamu alaikum jami'an. Good evening. Thank you very much for the kind introduction, and thank you to the Emirates Diabetes Endocrine Society and the ADA for the kind invitation. So I hope you can see my slides. So over the next 20 minutes, I'll speak about some of the regional experience that we have had over the past few years to utilize diabetes technology in our region. So these are my disclosures. And I will try to present some examples of how advances in diabetes technology are currently shaping healthcare services in our region. And maybe since I come to you from Riyadh, I will focus my discussion around some of the um, experience from Saudi Arabia. And I will limit my talk to our experiences with diabetes technology in relation to data collection, in relation to how technology advances are shaping insulin delivery, and also how we are utilizing technology to interpret data and use data to improve outcomes. And I think before I do that, I wanted just to make sure that we're all familiar with the Internet of Medical Things, because almost all of the discussion that I will be having focuses around this concept of IOMT. So it's the network of internet connected medical devices and software applications used to connect healthcare information technology. So it allows wireless and remoted devices to communicate over the internet. And in the healthcare sector, it allows for rapid and flexible analysis of medical information and data. Over the past few years in Saudi and at King Saud University and some of the other regulatory bodies in the region, we've been working to transform diabetes care utilizing 4 key steps, or what I would call them the tips. So we've been working on tailoring the goals and protocols of diabetes care to our regional needs. We've been working on innovation in diabetes care delivery, trying to prioritize and incentivize the efficient and cost-effective care model. And along the way, we have been studying the impact of these interventions and modifying them whenever needed. And the ultimate goal is to reach a care model that is based on value, where cost in one hand is considered, but also the clinical benefits and outcomes are also considered. And as you all know, it's the intention to always make sure that the healthcare services that we provide are not only clinically effective, but also financially effective and cost effective. So I think there is no better example to highlight the localization of protocols and guidelines than the example of diabetes technology and Ramadan fasting. And I'm happy that Dr. Mohammed Hassanein, who has been a champion in this field, is with us tonight as a speaker. So some of the work that I've been doing with my research team over the past 5 years has focused on this area, where we've explored the utility of diabetes technology and digital health tools in facilitating Ramadan fasting for people with diabetes. And this is just an example of one of those studies, or one of our initial studies that showed clearly that the use of automated insulin delivery systems, just like the ones highlighted in the previous talk, the use of these advanced technologies not only helps people with diabetes to fast more days of Ramadan, but also to have what I would call an optimal glucose control during the month of Ramadan. And if you compare that experience for AID users to the experience of people with type 1 diabetes who are on injections, you could see the significant difference between these experiences. So on one hand, people with diabetes who use multiple daily injections, with or without continuous glucose monitors, they often struggle with hypo or hyperglycemia during the month of Ramadan, and many of them are not successful in completing the Ramadan fasting. And then we've done some studies to look into how automated insulin delivery systems do help people with diabetes in achieving these excellent clinical outcomes during Ramadan. And since those systems are automated, we wanted to see what happens to insulin delivery in these automated insulin delivery systems during Ramadan, to better understand the physiology of fasting and how it impacts insulin needs and insulin requirements during Ramadan. And what you could see, just as an example of one of those studies, is that the total daily dose of insulin does not change in people with type 1 diabetes during Ramadan if you compare it to the total daily dose of insulin before and after Ramadan. What does change, however, during Ramadan is the proportion of basal insulin to bolus insulin between the daytime and nighttime of Ramadan. And long story short, people with type 1 diabetes during the daytime of Ramadan, they utilize more basal insulin than bolus insulin, whereas overnight things change. So they depend more heavily on bolus insulin compared to basal insulin. And that makes sense because that's the time of the day or night when they are actually eating. What you could also see in these systems during Ramadan, especially during the nighttime of Ramadan, is that the automated insulin delivery system tries hard to compensate and counteract the hyperglycemia that happens during night with giving more automated correction doses of insulin. And lately, just this past Ramadan, we did another study that we have not published yet, but I thought I would show it to you tonight, where we took different types of insulin pumps, going from the least automated insulin pump, where there is essentially no automation, a sensor and a pump that are not integrated, to a semi-automated pump where the only feature that this pump would have is suspension before low, to a completely automated insulin delivery system where the basal insulin is automated every 5 minutes. And in the background, the control group is the multiple daily injection group. And you could just see how as the level of automation increases, the glucose control gets better during Ramadan. Not only that, but we also evaluated the level of fear of hypoglycemia among these people at the end of Ramadan. And you could see that essentially everyone is anxious, everyone is worried about hypoglycemia during Ramadan, but the automated insulin delivery users had the least hypo avoidance behaviors. They were the least likely to make actions to prevent hypoglycemia. The other example that I wanted to show you in terms of how we're utilizing technology in our region is around the topic of shaping clinical practice guidelines. We've met with a group of experts in the field of diabetes and Ramadan and diabetes technology. And we've worked together to publish these recommendations on the use of the MiniMed 780G system during the intermittent Ramadan fasting. And you could refer to this paper that was published end of last year or earlier this year. What I think is a more remarkable achievement in this field from our region is the updated standards of care from the ADA that was released a few weeks ago, updating the DAR-IDF risk calculator led by Dr. Hassanin and the group. And I think this is just a reflection of a lot of the studies that have been done in our region in terms of the use of diabetes technology during Ramadan. Now users of AID systems, new users of continuous glucose monitors are assigned lower scores on this updated risk calculator. In Saudi, we have been trying to shape policies when it comes to the utilization of diabetes technology and accessibility to diabetes technology. We've published the first national diabetes technology report in the Journal of Diabetes Science and Technology, where we list some of the challenges that we're currently having in Saudi and maybe shared by several other countries in the region, and how we plan to address them over the next 5 years as part of the efforts to accomplish some of the goals of the Saudi Vision 2030. In terms of innovation in diabetes care delivery, I think the previous speakers have nicely explained the current burden of diabetes and also the current burden of diabetes on the healthcare system and how patients are navigating the current healthcare system. So I don't think I need to explain to this audience how challenging it is for a person living with diabetes to navigate through our chaotic healthcare system. And what I think is going to be the future, if it's not already being done in your region, is that we're transforming diabetes care. And instead of having patients travel around to meet with all these specialists, those specialists can be brought to the patient or the person with diabetes wherever he or she lives through telehealth. And we've been doing some work around this, maybe accelerated by the COVID-19 outbreak, where we're typically using telehealth as part of our clinical care, even nowadays, 5 years after the COVID pandemic. So the beauty of diabetes is that the diabetes care is heavily dependent on data. And the beauty of diabetes technology is that we can now remotely transmit these data through the cloud from clinics to patients and vice versa. So we've been trying to take advantage of this. A lot of our clinical services nowadays are provided remotely via telehealth that can be in the form of audio telehealth or visual telehealth. You may remember during the COVID pandemic, this was the only way we communicated with our patients. We were able to do physical exams through telehealth. We've onboarded patients on insulin pump CGMs remotely, and we've become better at doing this. So in the interest of time, I'll just skip some of those slides. These are basically to show you some of the data that we've published showing that the use of telehealth in the form of video and audio or audio-only visits do help with improving glucose control in patients with type 2 diabetes, as well as in patients with type 1 diabetes, especially those who use CGM and can transmit their data remotely to our clinics. And it's not just the fancy insulin pumps and continuous glucose monitors that can be utilized as a diabetes technology tool, but also patients who are using glucose meters or blood glucose meters nowadays can utilize Bluetooth-enabled glucose meters where they can download an application on their phones, and whenever they check their glucose or their blood glucose, that number can be transmitted automatically to our clinic's account. And we also provide these patients with an application that helps them titrate their basal insulin between clinic visits according to their fasting glucose. And this is just as an example of a patient that we started him in the clinic on 13 units. We gave him the application to titrate that basal insulin according to fasting glucose. And you could see that the dose was increased to 19 units automatically by the app. And then one day the patient had a close to hypoglycemia event, and the app automatically reduced the basal insulin dose to 15. So all of this was happening between clinic visits, just a blood glucose meter with an application. And you could see that within 3 months or 4 months, A1C came down very nicely. We've also published our data on the utilization of blood glucose meter with this application that titrates basal insulin. This was a multi-center study with some of the centers in Saudi and Desman Center in Kuwait. And the short story or the short version of this story is that the system works, especially if patients are engaged with the technology and with the application. We've also done some work in terms of utilizing diabetes technology as a behavior modification tool. And this was inspired by one of our earlier studies led by one of our previous fellows, who's now a consultant in Bahrain, Dr. Abtihal Al-Yusuf, where we found that people using CGM who are more engaged with the sensor, we called them at the time frequent users. They used to do more frequent CGM scans. And those were the ones who experienced more rapid improvement in their glucose control compared to those who were infrequent users or less engaged with the system. So that was one of the earlier lessons for me personally, that patient engagement with technology is key in the success of utilization of diabetes technology. We took those lessons to build one of the Saudi digital solutions that helps with improving patient engagement with technology in the form of using CGM data as a gamification tool, behavior modification tool, where patients can collect points as long as they have glucose levels within target. They can compete among the diabetes community in the application. And we incentivize them as well with money in return if they keep their glucose within target more than others. So 3 or 4 years ago, or maybe now it's almost 4 years ago, I wrote this chapter for the Diabetes Digital Health and Telehealth in the US. And at that time, I was proposing some initiatives that I believed at the time would improve the accessibility to diabetes care in the Middle East and North Africa, would improve the efficiency of diabetes care, as well as the quality, safety, and affordability of diabetes care. And you could see these different elements, including the utilization of insulin pumps, mobile health applications, wearables, telehealth in different forms, And I'm happy that now, 4 years later, we've been able to accomplish a lot of these things that I dreamed about 4 years ago. One of these solutions that I briefly mentioned is a Saudi digital solution, Karaz, where we have an application that integrates data from different continuous glucose monitors, different automated insulin delivery systems, and put them together in one platform to work toward interoperability of these devices. And in addition to the gamification that I briefly mentioned, we also incentivize patients for their health promoting behaviors in an effort for us to keep them engaged with the system and also to improve their glucose control. And we just a few months ago or a few weeks ago published our first paper in the scientific reports in Nature, showing the impact of this monetary incentives and gamification on glucose level, showing that it is very effective, especially in patients who are struggling with poor glucose control at baseline. So if you put them into a gamification protocol that incentivizes them for health promoting behaviors, they tend to do better. So I think I know we're running out of time, but this is my last part of the talk where we talk about the development of new metrics to help with data interpretation. So CGM reports are very long reports, busy reports that we don't often have the time in our busy clinics to go through. So one of the things that we worked with Diabetes Technology Society in the US to optimize is the GRI metric, or the glycemia risk index. So this is a one number that takes into account hypoglycemia, hyperglycemia, and gives different weights to each of these metrics. But it gives you a better idea of glucose out of range and whether or not your patient is high risk, medium risk, or low risk. And we take that number and we utilize it now in our clinic to prioritize our patients and flag those who are struggling the most. Again, the idea here is to optimize the healthcare model to be closer to what I would call the value-based care model for diabetes, where we aim to be efficient as clinicians and not at the expense of the safety of the diabetes care model and services that we provide, with the ultimate goal to achieve quality and affordability of diabetes care that is accessible to everyone. So with that, I conclude, and I'd like to thank everyone who has helped us throughout these projects, and I'm happy to take any questions or comments. Thank you.
Thank you so much, Dr. Mohammed. Very nice and clear talk. It's time for the Q&A session. I'm going to have a look how many questions. Dr. Mohammed, let me start with the first question. The adaptation, the use of advanced technology and technology in general in diabetes care in the Gulf states. Are we lagging behind? Are we adopting the technology at a slower rate? What do you think?
So that's an excellent question, and I think I would answer it in two parts. So the first part, so are we behind in terms of adaptation of diabetes technology? I think the answer is yes. So if you compare the proportion of patients, let's say with type 1 diabetes who are on insulin pump or CGMs in our countries, the percentages are much lower than those in the Western countries. The same is true and maybe even worse for people with type 2 diabetes. If you look at the use of CGM, and definitely the use of insulin pump is very low or extremely low in that population. The other part of your question is, are we slow in adopting these technologies? So I think for the past 3 years, I think most of us, including policymakers, have come to realize that we're late and we're lagging behind others in this area. And I think that has accelerated the uptake of diabetes technology in people with type 1, certainly. And I think we're starting to see the same in people with type 2 diabetes, especially for the use of CGMs.
Okay. Thank you so much. Thank you. We'll move to the Q&As. Now, there's a question. Are there any plans for initiating diabetes technology virtual program for health professionals? Yes, I'm going to project one slide. There's ongoing program now with the American Diabetes Association. Just bear with us, and we're going to tell you the link for that. And the second question is being targeted to Dr. Mohammed Hassanein. Thanks, Dr. Hassanein, for excellent lecture. Can you please reiterate the point of the mirror image of people who do not exercise and those who are not obese? Thank you.
Sure. Thank you very much for the question. It's really quite an important one. In the Dubai's household survey, which was done according to the WHO criteria of household visits on one-to-one, we looked into the prevalence of diabetes in people who were of normal weight. It was around 8.5%, and people who were obese, it was 21%. If you look into the same prevalence of diabetes, regardless of weight, those who were exercising, it was 8.8%. Those who were not exercising, it was roughly 21%. So the mirror image is, if you're exercising or if you have normal weight, your prevalence of diabetes is under 9%. And if you're the opposite, if you're obese or if you're not exercising, the prevalence is 21%. So this is really quite an important message, because it's not just focusing on weight loss, but focusing on increasing the physical activity, whether it will lead to weight loss or not.
Excellent observation and finding. Another question is, changing lifestyle can affect or delay diabetes. But what about patients with dementia or geriatric patients? Is the implication still there, or is it late?
Well, the physical activity is not very much related to the memory. Of course, many people who have dementia are relatively have a level of frailty with their physical ability. But nevertheless, the choice of what we eat, unfortunately, in our region, our food is very rich in carb, and as you saw from the data, much lower in fruits and veg. So even for elderly people, choosing the right type of food is really quite important to help avoiding progression of the problem. And the role of technology here is not necessarily, of course, in the CGM, of course, in the delivery of insulin, but equally important in the education and in the remote clinics. Someone frail, I don't want them to come to clinic, but it would be lovely if they have a CGM. I can review their figures. I can call them via video call or teleconsult. I do a teleconsult every Friday, teleclinic every Friday, smart clinic. And we convey the message to either the person or their carer.
Yeah, and the uncontrolled diabetes will accelerate the process of dementia or Alzheimer's or other diseases.
Of course, with the acceleration of the atherosclerotic problem and the negative impact of hyperglycemia and hypertension and so forth.
Yeah. Okay, another question for Dr. Mohammed. Can we generalize the KRAS app to be used in the GCC countries? Is it strict? Do you have a patency on it, or are you generous to generalize it?
So it is available. It's being used in some of the centers here in Saudi and also in Imperial College in Abu Dhabi. We launched it, I think, 3 months ago. And the short answer is yes. And I'm happy if you could reach out to me, anyone who would like to explore this further. I can link you with the team for sure.
Thank you. They could get your email from your application probably, and they contact you.
Correct.
Thank you. Is this the medicine effective all over Saudi or only Riyadh or major cities?
Yeah, so I think the question is about telemedicine. Sure. So based on our data, I think we had in one of the studies, 30% of the participants were from outside Riyadh, mostly small cities around Saudi. And we saw no differences in terms of the effectiveness by area of residence. Obviously, one of the key elements for the success of any telehealth model is the availability of internet and broadband coverage. And I think in Saudi we tend to have good internet coverage across the different parts of the country. But I think for any other country that would like to adopt such a care model, that's one of the factors to be considered.
Yeah. Other question. What are the substitutes for diabetes technology or CGM in low-income country who cannot afford for such high cost? Another way, put it this way, is there any cheaper alternative that could be applied for countries with low income?
So I can take.
Yeah, I was going to ask who's that question for?
I can take the first half of that question. There are different companies are offering CGMs with less features in order to reduce the cost. For example, I know of Dexcom providing the Dexcom One in some part of the world that reduce the cost. There are also some earlier version of CGM. For example, if we talk about Abbott, there is the Libre 1, which is a scan, or the Libre 2. The latest version or the latest generation is the Libre 2 Plus and the Libre 3, but the previous ones are a little bit cheaper. Having said that, the cost is a burden in many, many countries. But I think companies are trying to do their best as they can without losing revenue, which is the point of a commercial endeavor. But they are trying to present with options for different countries at different geographies, and also in different parts of the world. I know in Latin America, Abbott has big presence, Medtronic has big presence, Dexcom is only available in Argentina, for example, if we talk about Latin America or in the American continent. And also it's important how the system in your country works. There are countries with more social medicine, where the government or some public health insurance cover, Medicare, Medicaid in the case of here, and there are other countries that only work with private health insurance. So that depends. But I think societies, advocates, and people are working hard. ADA, EASD, ISPA are working hard to deliver the best they can.
Thank you. Thank you. Right. Extensive answer. Thank you so much, Daniel. And this question as well, how can technology and AI help in giving more time and offering counseling to people with diabetes? We'll take this question. It's quite a broad one.
So I can take that one. So this is one of the potential benefits of technology and AI is to ease the burden on HCPs and take care of some of the part of our work that we probably do not need to be doing over and over. So automation of some of the regular tasks that we have as clinicians is a potential use of technology, and that would free us to do things that I would say matter more to us as clinicians and matter more to our patients. So you could just take as an example dealing with health insurance reports, submissions, appeals, etc. If technology and AI can take care of that part, we could spend more time with our patients, counseling them about their lifestyle, the best way to approach their disease, manage their disease, etc.
I can expand on this as well. Yesterday, I was in Kuala Lumpur, in Malaysia, for a meeting, and we were discussing more or less the same. So, group digital education could be already delivered as a recorded video or message or AI technology utilized, and then the person would only get involved in the Q&A. So instead of sitting in clinic and repeating the same message over 20, 30 minutes or an hour for every patient, it could be done in a group over an hour. It's pre-recorded, it's maybe a module, it's maybe some using technology, and then the healthcare professional will be involved for the 10, 15 minutes of Q&A. Imagine, for example, this webinar, it could be, instead of a lecture, it could be maybe a educational module. And then they go in to meet the expert and have a Q&A with the expert. So there's lots of ways to save time for us to do other things. If you think of the fasting risk calculator, it's a sort of AI. You answer the different aspects and it give you a score. Using what? Using the technology of a factor for the problem. And that will save time. So I'm certain that if we are to use it in a good way, especially when first introduced by the healthcare professional, it would be of a very good use.
Yeah, thank you so much. I think with this, we come to the end. Thank you so much for delivering interesting talks and for interactive discussion as well. I would like to thank our excellent speakers for their wonderful talks. And thanks so much to our audience. We exceeded almost 300 attendees. Pleasure to have you all from the first minute until the last minute. And this is a CME accredited activity. Please write your name clearly as you would like to see it in your CME certificate. You're going to receive your certificate within 14 days. It is accredited by the Dubai Health Authority. And we should remind that this activity, the second episode with the American Diabetes Association. And for you to be a member of the association, you could log in the main websites. And there is a tier 1 and tier 2 regarding the MENA regions where you get membership. And if you enter this code in, you could get 10% discount for the ADA membership. Next slide. We have joint activity with the American Diabetes Association.
Can you show the last slide, please, Professor Juma, again, to take a screenshot and share it with our colleagues and friends in the region?
Could you go back? Could you go back? Yeah. Yes, please, here. So you could go to the website.
Yeah, thank you.
Thank you so much. Could you go forward? Next slide. Yeah. Making Diabetes Technology Work continuing education program. This is ongoing program between the American Diabetes Association and the Emirates Diabetes and Endocrine Society. And this is 3.5 CME hours. And please keep in mind, this offer is closing by the end of this month. So 31st of December is the last day. And you could get through this link over here. You could register easily, and you're going to get 3.5 CME hours and enriching your knowledge in the applying of the technology in diabetes care. Not to forget, and please block your calendars, block your clinics for this important day. our usual international annual Congress meeting for the society is going to be from the 6th to the 8th of February 2026. It's just a few days before Ramadan, and we're looking forward to see you there. And please pass on the message to whoever you know about this big event. We have a rich program. You could review the scientific program on the website of the society. And with this, we come to the end. Thank you so much for being with us, and it's a pleasure to have you. Thank you, and have a good night.
Thank you.
Thank you.
Thank you.
Thank you. Take care.
Take care. Ma'as salama. Bye-bye.
Thank you.